Hello, good morning. Morning. Is everybody there? Yeah. Can you hear me? Could somebody respond that you can hear me? Yeah, good morning. Rajista Yunus said, good morning, sir. Good morning, everybody. Yes, excellent. So I hope that everybody's there, wide awake. Good morning, M15. कल ही आपकी डेट शीट भी मिल गई है, so good news for your final professional examination. Yeah, okay, thank you. तो मेरा ख्याल है सबको पता होगा कि your exam final professional starting on the 9th of February, medicine 1, medicine 2 is 12th of February. Then the surgery comes in on 16th of February, surgery 1. On 19th is surgery 2. And then comes your ops and gynae. Ops on 23rd of February. And gynae on 26th of February. Peds on 2nd of March. So 9th of February से लेके 9th February से start हो रहे हैं आपके एग्जाम till 2nd of March. और इसका मतलब मार्च में उसके हफ्ता के बाद आपके वाइवल्स शुरू हो जाएंगे. तो थोड़ा सा इट्स अ बिट ऑफ अ डिले, लेकिन आई थिंक हम लोग चाह रहे हैं कि आपका क्लिनिकल थोड़ा सा व्हेन यू कम बैक और ट्राई. आज अभी मेरी ऑन माय वे टू दिस लेक्चर आई मेट प्रिंसिपल और मैंने कहा कि अगर आपको थोड़ा जल्दी बुला लिया जाए ताकि आपकी जो क्लिनिकल साइड है उसको भी थोड़ा सा ब्रश अप कर दिया जाए और we should cover that as well, right? So should be starting from 9th of February. तो अपना तैयारी कर लो कि भाई अब डॉक्टर बन गए हो तो सिर्फ एग्जाम ही क्लियर करना है. एंड आई एम श्योर हमारा रिजल्ट तो माशाल्लाह यूजुअली 90s में होता है, 90%, 95, 96, 97. And if we are lucky, you might get 100% results. Inshallah, ठीक हो जाएगा. But you got to work hard and start studying properly now. You've got a few months left. So hopefully, next month is August. August के लगता है August के बाद August भी ऐसे ही चलेगा. Online lecturing, and then after that, we'll probably face to face आगे lectures होंगे, discussions, but we'll be stressing more on the clinical practical side and examination wards में. तब तक मेरा ख्याल है patient भी कुछ आने शुरू हो जाएंगे. When you'll be here, things are improving. So far as COVID-19 is concerned, Pakistan में अल्लाह का रहम है, around 1,000 new cases होते हैं, and deaths are in 30s now, less than 40 every day. So the things are improving. Hopefully, हमारी routine जो practical classes हैं वो start हो जाएंगी. Sorry about that. Now, just to recap, last time हम थोड़ा upper abdominal pain में we were discussing gallbladder plus the differential diagnosis of acute cholecystitis. So as you can see, हमने क्या क्या डिस्कस किया था. We talked about the anatomy, क्योंकि anatomy कभी कई दफा क्वेश्चन आ जाता है. We talked about the gallows triangle. Where was it? Gallows triangle. That's the gallows triangle. Okay. The common hepatic on the medial side, and superiorly you have lower edge of the inferior edge of the liver, and inferiorly You have the cystic duct triangle, and the contents are the cystic artery, the red colored cystic artery, okay? And some few lymph nodes, especially lymph node of Lund at the Hartmann's pouch, and some lymphatics and some other lymph nodes as well, okay? So we discussed about the pathogenesis of gallstones. We also discussed about the clinical presentations, risk factors, and we also okay, sorry, there was a bit of a problem in connection, but hopefully we are back again. So as you can see on this calcified wall of the gallbladder, this plain filled. So that's an indication that we should go for surgery because there are chances it might be malignant one. Okay. And last time I also mentioned that 10 to 15% cases, if you do a plain X-ray, the stones can be radio opaque. So 10 से 15% लोगों में plain X-ray पे stone आ जाते हैं. Then I showed you the CT scan with calcified wall of the gallbladder and sometimes the gas in the lumen of the gallbladder. That's the gallbladder. And can you see the gas lining of the inside of the gallbladder? And there is some gas in the lumen. Okay. Now, they sometimes asked you about pneumobilia. Pneumobilia, that means air in the biliary tree, air in the gallbladder, in the biliary tree itself. Then how do you get air there in the gall? Usually there is cholecystoduodenal fistula. Inflammation की वजह से क्या होता है, इसमें stones होते हैं, the stones keeps on eroding, तो ये इस wall को erode करके ये उसके duodenum उसके साथ जुड़ जाती है, तो cholecystoduodenal fistula बन जाता है. If some of the stones from the larger stones from the gallbladder, they migrate into the duodenum directly. ये जो fistulous tract बनी होती है उसमें आ जाते हैं, and some of the gas from the duodenum goes into the gallbladder. So you see a gas in the gallbladder and the biliary system, which is called pneumobilia. Okay, pneuma means air. Some air in the biliary system, that means there is a fistula between the bowel and the gallbladder, usually the duodenum. The duodenum is closer to the gallbladder. जो इन्फ्लेम होगा, जो बड़ा होता जाएगा, इन्फ्लेमेशन होगी, ये उसके साथ जुड़ जाएगी, and आहिस्ता आहिस्ता that stone in the gallbladder erodes through into the duodenum. Duodenum से आगे गुजरता stone जो है, it goes, and the narrowest part जो वो of the bowel जो होता है ना, उसमें आके वो stuck कर जाता है, and it causes intestinal obstruction, small bowel intestinal obstruction. You can see air fluid levels there. That means one of the stones have come down, gallstones have eroded through the fistula, cholecystoid fistula, causing pneumobilia, and the stone has caused obstruction of the small bowel. Okay, I'll show you the X-ray with the stone in next few slides. जिसमें कि stone भी है, उसने bowel को obstruct किया हुआ है. तो ऐसी कंडीशन को वी कॉल इट गॉलस्टोन आइलियस, राइट। इसमें सिनेरियो ये बनता है कि दे कैन आस्क यू what is the diagnosis, that the patient with known gallstones presents with abdominal distension and vomiting. जब abdominal distension और vomiting का मतलब है कि intestinal obstruction हो गया। known gallstones का मतलब ये है कि gallstones हैं उसमें, and they'll also say that there is a pneumobilia, okay, and multiple air fluid levels, the X-ray. So there are a few things: known gallstones, pneumobilia, and abdominal distension with multiple air fluid levels. What is the diagnosis? The diagnosis is gallstone ileus. Okay, so remember that. And I showed you the acoustic shadows. I'm just trying to revise you just the important salient pictures. Acoustic shadows of the gallstone, these black shadows. They are on the ultrasound scan. You see these acoustic shadows that confirm that we have the stones here in the gallbladder. Then the endoscopic ultrasound with an endoscope in the lumen, in esophagus, stomach, and see the CBD diameter, pancreatic diameter, and the rest of the structure around the stomach, the liver. Okay, and then also you can see the gallbladder here, calcified area on a CT scan. Then I also showed you what is HIDA scan is. Okay, so the liver, the biliary radicals. Then I also showed you the area gallbladder with some dilatation of the biliary system. That's it looks a bit bizarre, irregular. There might be chances of a malignancy here. Similarly, you can see the gallbladder with gallstones and thick wall of the gallbladder. And you can also see the PTC, and you can see this dilated intrahepatic ducts, biliary ducts. Okay, and I showed you last time this ERCP. You can see this scope going down into the duodenum, and through that cannula, the dye or the contrast is injected and is going into the right and left hepatic duct and common hepatic duct and the common bile duct. Okay, that's a small cystic duct here. Okay, and this is supposed to be gallbladder. Okay, you can see this similar picture of ERCP, and you can see the stones there. Okay, on this side, this is a bile duct, and there's a missing portion. It's a malignant structure in the bile duct. Okay, so you can see the malignant structure or cholangiocarcinoma in the bile duct. Okay, now this is again a picture of PTC, percutaneous transhepatic cholangiography. This is a tube inserted, injected. You see within the intrahepatic biliary dilatation, and on this side you can see multiple stones in the bile duct. Okay, that's a bit of a duodenum. So that means the contrast injected, multiple stones there on the CBT. There might be a question asked: discuss the management of common bile duct stones. Okay, so I'll show you the in a few pictures what is the management of CBD stones. Most of the time nowadays we're doing ERCP and we remove the stones and do papillotomy or sphincterotomy with an ERCP. Okay. Then we talked about different complications due to gallstones. As you remember, we talked about complications of gallstones in the gallbladder. In the gallbladder, they call biliary colic. They cause acute cholecystitis, chronic cholecystitis, recurrent attacks होते हैं cholecystitis के. It can cause mucocele, empyema of the gallbladder. It can perforate. Now, these are the complications in the gallbladder. Complications of gallstones, and the stones are in the gallbladder. Now, that stone moves from the gallbladder and goes to the CPT and blocks it. It's called biliary obstruction. Okay? And if that obstruction causes rigors, chills, high temperature, high bite count, also it causes bacteremia and septicemia. This causes acute cholangitis. And people with cholangitis is not only bacterial septicemia, people can have a renal failure. They can die of renal failure because this septicemia affects the kidneys and causes renal failure because of acute cholangitis. And we also discussed about the pancreatitis, acute pancreatitis. This is also, there are so many other causes, alcohol, drugs, infections, and gallstones. The gallstones in Pakistan, there are multiple small gallstones, and they migrate from the gallbladder to the bile duct and through the common channel. If they block the duct, it can cause gallstone pancreatitis. Okay, and if there is a intestinal obstruction, that means due to gallstones, it's called gallstone ileus. As I mentioned earlier in the beginning, there is a gas in the biliary tree called pneumobilia. There is a cholecystoduodenal fistula, and the stone migrates from the gallbladder into the duodenum, and duodenum थोड़ी बड़ी होती है इसलिए वहाँ से गुजर जाते हैं तो स्टोन गुजरते गुजरते फिर जब टर्मिनल आइलियम पहुँचता है which is the narrowest part, वहाँ जाकर स्टोन ब्लॉक कर देता है. ओके, स्टोन ब्लॉक करेगा स्मॉल बाउल को, तो स्मॉल बाउल ऑब्स्ट्रक्शन हो जाएगी. So this small bowel obstruction due to gallstones called gallstone ileus. Ileus is that जो small bowel की जो movement है वो stop हो गई है and it has caused an obstruction. Okay, ये हो गई आपकी effects and complications of the gallstones. Jab bhi somebody asks you about the different complications due to gallstones, complications of gallstones in the gallbladder, complications of gallstones in the bile duct and in the common channel, causing obstructive jaundice, causing cholangitis, causing gallstone pancreatitis. And if there's a fistula between gallbladder and the bowel, duodenum, causing pneumobilia, and the stone can move to the terminal ileum, blocks the obstruction of the small bowel. It's called gallstone ileus. Now, the next part is very important. Is that you see incidental gallstone from the ultrasound scan. उनको पता ही नहीं होता, and They come with an ultrasound for some other reason, और उसमें लिखा होता है कि गॉल स्टोन, मुझे तो कभी पेन नहीं हुई, मुझे तो कभी कुछ नहीं हुआ। सब टाइम में थोड़ा सा हाँ खाने में थोड़ा फ्लैचुलेंस हो जाती है, डिस्लेक्सिया हो जाता है। So routine cholecystectomy is usually not indicated, या foreign gallbladder निकालने. But if it's causing problems, if it's causing symptoms, then you can think of doing the cholecystectomy. Okay. Now, starting right from the beginning to reach to a diagnosis, we say a patient with postprandial pain which comes and goes, waxes and waning mean comes and goes in the upper quadrant epigastric region, and or sometimes there is a transient blockage of the stone in the cystic duct, उसकी वजह से भी biliary colic हो जाती है. But remember, it's just a biliary colic, so there will be no raised temperature, no leukocytosis. LFTs, liver function tests, will be normal. Liver function test क्या हैं? AST, ALT, जिसको SGOT, SGPT भी कहते हैं, ALT, AST, and alkaline phosphatase, which is very typical of biliary obstruction. It is a raised alkaline phosphatase. So in biliary colic, apart from pain due to gallstones, there are no constitutional symptoms, no fever, no leukocytosis, normal, everything normal. Okay, but if there's a fever with this pain and leukocytosis with positive Murphy's sign, that would be acute cholecystitis. Okay. Then we mentioned about now this is an ultrasound scan. Okay, and you can see these tiny, small, multiple gallstones. अच्छा एक और चीज़ यहाँ आपको बताते चलूँ, if you got big stones, दो तीन चार पड़े हुए बड़े stones हैं, उनमें इतना खतरा नहीं होता. ये जो छोटे लोग होते हैं ना, छोटे stones होते हैं ना, multiple, they are more problematic. और उनके लिए ज़्यादा वेट नहीं करना चाहिए. If you see multiple small gallstones, उनको जल्दी से उनसे कहें कि आप ऑपरेट करा लें. The reason being, ये small stones जो होते हैं ना, they can easily migrate from the cystic duct to the bile duct. और bile duct में आके they can cause cholangitis, they can cause biliary obstruction or obstructive jaundice, और थोड़ा सा और नीचे गए तो जाके ये gallstone pancreatitis भी कर सकते हैं. Okay, so these multiple small stones अगर हों, so that's you've got to keep an eye कि इनकी जल्दी cholecystectomy हो जानी चाहिए, so that अगर बड़े stones हैं तो कोई नहीं, you can wait a little longer. The small stones, multiple gallstones, as soon as possible, get rid of it to avoid any future complications. Okay, if there are recurrent attacks of biliary colic, leads to some fibrosis, repeated inflammations, it's called chronic cholecystitis. Similarly, there's no evidence of any fever or anything. Okay? Chronic cholecystitis, acute में होता है, chronic में leukocytosis fever नहीं होता. So this again, chronic cholecystitis, it causes scarring, fibrosis, shriveled up छोटा सा gallbladder जुड़ा हुआ सा पड़ा होता है, and it's most of the time it's due to gallstones, and recurrent attacks of biliary colic होते रहते हैं. So the treatment is cholecystectomy. Okay, remove the gallbladder. Now, the other things of differential diagnosis, right? Upper quadrant pain, as you know, it could be perforated ulcer, pancreatitis, hepatitis, and rule out these appendicitis, renal colic, pneumonia, pleurisy, as well as MI, rule out MI. Okay, I still remember that. In London, when I appeared in lab examination, मैंने कहा था कि my examiner or a physician, a gynecologist or एक professor था कोई और. So physician asked me that he had a fish pie last night and now he has some reflux symptoms in the epigastrium and retrosternal. So what do you think is the diagnosis? देखा मैंने रात fish pie खाए थे और मैं कोई 50 years old हूँ और मुझे रिफ्लक्स सिम्टम्स हो रहे हैं और एपिगैस्ट्रिक डिस्कम्फर्ट हो रहा है, तो व्हाट इज द लाइकली डायग्नोसिस? तो मैं तो कहा कि गैस्ट्राइटिस है, ये वो है, कुछ भी गॉलस्टोन, कुछ भी समथिंग अल्सर, पैक्टिक अल्सर हो सकता है, कहता और एंड तो द थिंग ही वाज ट्राइंग टू कम एट कि वो ये पूछना चाह रहा था. फिर मैंने उनको कहा कि आई विल डेफिनेटली एक्सक्लूड as you are 50 plus and this is retrosternal discomfort and epigastric pain. It could be a referred pain because of MI. So never forget the differential diagnosis in epigastric pain. Never rule out the myocardial infarction, the heart problem. And well, every time I would like to mention the person who was sitting next to the professor of medicine, professor of gynecology. His name was Professor Pinker. He asked me about laparoscopy at that time. जबकि laparoscopy अभी पिछले इससे 1 साल पहले शुरू हुई थी दुनिया में in France. So his name was Professor Pinker. And he was a personal gynecologist to Lady Diana. So imagine ऐसे लोग हमारे examiners थे. Okay, so never forget, the lesson is never forget in epigastric pain, rule out MI, myocardial infarction. Okay, so now come back after biliary colic. The other scenario is because of gallstones, you get acute cholecystitis, not only pain, but is because of inflammation, infection of the gallbladder, is an edema. आपको पता है ना, edema भी होता है, pain भी होती है, redness भी होती है, all signs of acute inflammation. Calor, rubor, dolor, pallor, and function leso, loss of functions, redness, pain, inflammation, okay, edema. And how you can do that? There'll be raised temperature, there'll be fever, there'll be raised white cell count because of the infection, and there will be Murphy sign positive. Inspiratory arrest. आप जब सांस लेते हैं और आप उसको दबाते हैं during inspiration, okay, not during expiration, during inspiration. Inspire करने से क्या होता है? The diaphragm goes down, the liver comes down. जो ही आप प्रेस करते हैं तो गॉल ब्लैडर भी नीचे आता है, तो वो palpation पे, deep palpation पे, patient will have pain. Okay, that's called Murphy sign positive. Right. The next one is now what do you see? कहते हैं अल्ट्रासाउंड स्कैन जब आप करते हैं गॉल ब्लैडर का, which is the first choice, तो क्या आप देखते क्या हैं? Well, you see the gallstones acoustic shadow, you see the distended gallbladder, okay, gallbladder होगा, you see the gallstones, you see the acoustic shadow, You see the because of edema of the wall of the gallbladder, the wall thickens. वो more than 4 millimeter हो जाती है. Normally it's 1 millimeter or 1.5 millimeter. लेकिन जब बड़ी हो जाती है तो because of edema due to acute inflammation, the wall thickens. और some of the edema की वजह से कुछ थोड़ा सा fluid around the gallbladder इकट्ठा होता है, which is called peri around. Okay, उसके साथ साथ pericholecystic fluid जो अल्ट्रासाउंड पे नजर आता है. वॉल की थिकनेस आप बता सकते हैं, स्टोन बता सकते हैं, वॉल के बाहर थोड़ा सा फ्लूइड है वो बता सकते हैं, और पॉजिटिव सोनोग्राफिक मर्फी साइन. जब अल्ट्रासाउंड कर रहे होते हैं ना, जो प्रोब होती है ना, जो जिससे करते हैं, जो रब करते हैं उसके ऊपर, एब्डोमेन के ऊपर जेली लगा के, जो तो अगर आप ड्यूरिंग इंस्पिरेशन वो प्रोब को अंदर दबाएं बजाय हाथ से दबाने के, जो आप एग्जामिनेशन में करते हैं, दिस इज कॉल्ड पॉजिटिव सोनोग्राफिक मर्फी साइन. वो जब आप करेंगे प्रोब के साथ भी दबाएंगे तो इट विल बी पेन. तो यूजुअली रेडियोलॉजिस्ट लिख के आपको बताएंगे देयर इज अ पॉजिटिव मर्फी साइन विद द अल्ट्रासाउंड प्रोब. ओके, दिस इज वेरी स्पेसिफिक. तो और चीज़ें जो इसमें मेंशन नहीं की गई, आई ऑलवेज want to know the diameter of the CBD. कि आपने गॉल ब्लैडर भी बता दिया, गोल स्टोन भी बता दिया, acoustic shatter भी बता दिया. You told me the wall of the gallbladder is thickened. You also told me that there is some pericholecystic fluid. Okay, but I would also like to know what is the diameter of the CBD. Why do I want to know the diameter of a CBD? Because normal diameter of CBD is 5 millimeter to 7 millimeter in diameter of common bile duct. अगर वो 7 मिलीमीटर से ज़्यादा अल्ट्रासाउंड बता रहा है कि जी इसकी डायमीटर 1 सेंटीमीटर है, यानी 10 मिलीमीटर और प्लस है 1.2 सेंटीमीटर है, तो इसका मतलब है कि इसमें कोई स्टोन चला गया हुआ है और उसने उसको ब्लॉक कर दिया हुआ है, एंड दैट हैज कॉल्ड डायलेटेशन ऑफ द सीबीडी. ठीक है, तो इन दैट सिचुएशन I will not do cholecystectomy अगर CBD dilated है. ओके, जब भी cholecystectomy का पेशेंट होता है तो मैं उनसे ये कहता हूँ what is the diameter of CBD. अगर CBD का डायमीटर ज़्यादा है, that means there is a stone in CBD. आप गॉल ब्लैडर को रिमूव करके गॉल स्टोन को with the gallstone गॉल ब्लैडर रिमूव कर देंगे. What about the stone in the CBD? उसको प्रॉब्लम तो वही रहेगी, क्योंकि उसको कोलेंजाइटिस भी हो सकता है, पैंक्रेटाइटिस भी हो सकता है, बिलियरी ऑब्स्ट्रक्शन भी हो सकती है. तो ऐसी सिचुएशन में जब CBD का डायमीटर ज़्यादा हो तो कोलेसिस्टेक्टमी करने की ज़रूरत नहीं होती. पहले आप उसको ERCP के लिए भेजें, ERCP करके CBD का स्टोन निकालें ताकि बाइल ड्रेनेज इनटू द ड्यूडेनम इट शुड बी free drainage of bile before you actually remove the gallbladder, before you actually do cholecystectomy. The CBD should be clear. ठीक है, तो इसलिए it's very important कि अल्ट्रासाउंड जब आप करते हैं so you should know what is the diameter of the CBD is. I hope you understand what I'm trying to tell you. Now, the other thing is, अब ये अल्ट्रासाउंड किया आपने गॉल ब्लैडर का, there are multiple stones. ये देखिए 2 stones हैं, ये wall है, this is the neck of the gall bladder, इसमें 2 stones possible. If you look at these thickness of the gallbladder wall and some fluid around the gallbladder, pericholecystic fluid. Okay, so इन्फ्लेमेशन की वजह से गॉल ब्लैडर के बाहर भी थोड़ा सा फ्लूइड इकट्ठा हो जाता है। स्टोन्स इसलिए ये हैं कि कैन यू सी दिस अकूस्टिक शैडो नीचे जा रहा है, इसका भी और इसका भी। अल्ट्रासाउंड में क्या क्या चीज़ें आप देखते हैं? स्टोन, acoustic shadow, thickness of the wall, varicocystic fluid, and you also see the CBD diameter. Okay, never forget that CBD diameter. Now look at this scan and multiple lymph nodes. Okay, around in the islet region. That's the gallbladder, and the wall thickening. Some fluid around the gallbladder, some fluid there, there fluid, and it is also distended gallbladder, and there are few nodes there. Right, now the complications, we've already discussed that, but it is if it's obstruction of cystic duct, जब cystic duct block हो जाती है तो सारा कुछ उसके अंदर गॉल ब्लैडर के अंदर ही रहता है, बाइल जो है, और सारा पिगमेंट्स उसके एब्जॉर्ब हो जाते हैं और बाइल जो रह जाता है, इट बिकम्स वाइट बाइल. ओके, इट्स कॉल्ड वाइट बाइल, एंड दैट्स एन इंडिकेशन कि आप अर्जेंटली उसकी कोलेसिस्टेक्टमी करते हैं, because of a stone in the cystic duct, वो गॉल ब्लैडर डिस्टेंडेड होना शुरू हो जाता है, and it can get into empyema and perforation. So you better do an urgent cholecystectomy. Okay. Now, complications also include empyema, pus. They are filled in the gallbladder. You get high temperature because of the pus, and it can perforate as well. So emergency operation is needed in empyema. Next is if you see emphysematous gallbladder, I mean, in the wall of the gallbladder, there's a lot of gas, and this is usually seen in men and in diabetics. Okay, those who are diabetic and men, it can cause a generalized septicemia, emergency cholecystectomy, or urgent cholecystectomy is needed. Okay, what is emphysematous gallbladder? How does it look? If you look at it, it's all gas, distended gallbladder, and is the gas there in a diabetic male patient or diabetic, even in female patients, you get distended gallbladder, some gas in the gallbladder, the area because of infection, septicemia in diabetic patient, gas producing bacterial infection. Okay, they're more common in diabetics, so don't delay cholecystectomy in diabetic patients. Okay, it can easily get septicemia and can complicate things. Right. Just allow me a couple of minutes, please. Thank you. Hello? 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 G. We want some? Huh? हाँ जी जी जी, जल्द से. मैं बेटा लेक्चर दे रहा हूँ ना. हाँ, आप मुझे इसकी पिक्चर लेके भेज दो, मैं बाद में देख लेता हूँ. ओके ओके, थैंक यू. Right, so if you get the perforation, gangrenous gallbladder can perforate, and there is some abscess around the gallbladder. So it's a pericholecystic abscess. Then you can do cholecystectomy and drain it, or you can just, in an elderly patient, you can just drain it, drain the pus, and with antibiotic and fluid cover, you can do cholecystectomy at a later date in an elderly patient. But if it's a perforation and there is no abscess, but the whole of the peritoneum abscess सारी पस जो है ना अगर localized नहीं है और वो सारे abdomen में चली गई है, it has called peritonitis, free perforation, then emergency laparoscopy should be done. Pus should be drained, and cholecystectomy should be done to avoid any further complications. Now, if it's a chronic perforation causing cholecystoenteric fistula, air is seen in the biliary tree. As I mentioned earlier, it is a cholecystoduodenal or cholecystoenteric fistula. You see, this is called a pneumobilia, air in the biliary tree. The stone can cause small bowel obstruction, if large enough, called gallstone ileus. You do the laparotomy, you remove the stones at first place, and later on do a cholecystectomy and closure of the choleduodenal fistula. I said later on, at a second look. Don't attempt at the first go. You just remove the obstruction, get the patient better. And if the patient is all right after a few weeks, then think of dealing with gallbladder and that fistula. Okay. Now that's the picture I was waiting. Now you look at this X-ray. It's a plain X-ray. See, and you can see dilated small bowel loops. Okay. Dilated small bowel loops. Abdominal distension है, patient को abdominal pain हो रही है, patient is vomiting, and they will say that the patient is known case of gallstones. ठीक है, तो और there is some pneumobilia. ये जो gallbladder biliary tree है उसमें देखो गैस आई हुई है. Okay, there is a pneumobilia, there is a dilatation of the bowel, there is a double distension, vomiting. तो यहाँ से स्टोन निकल के इधर से होता होता यहाँ से आता आता ये देखो, that's a big stone which is blocking the small bowel, causing back pressure and obstruction. It's called gallstone ileus. Okay, that stone has come from the gallbladder, और इतना बड़ा stone है, it has come directly into the bowel. ये cystic duct और bile duct के through से होके नहीं आया, directly is formed a fistula. The cholecystoduodenal or cholecystoenteric fistula. Okay, इतना बड़ा stone which is about 2 centimeter diameter. Okay, ये CBD का diameter तो होता ही 5 to 7 millimeter है. तो ये उधर से CBD से होके तो नहीं ना आया. It has come directly. Okay, so always it's a very good X-ray, and you can see that there is a stone there. It's seen in the pelvis. Is blocking the bowel, small bowel, causing small bowel obstruction. There is a pneumobilia, air related tree as well. Okay, so the treatment is you remove this stone, relieve the obstruction first. Once you've done that, then you at a second date, at a later stage, remove cholecystectomy, do cholecystectomy and deal with that fistula in between the bowel and gallbladder. It's a difficult operation, so don't do that and this as well at the same time. Okay, so remember that. Now, the other thing, very important, you should remember, is जरूरी नहीं है कि gallstones ही हों. Sometimes patient has cholecystitis without stones. It's called acalculous cholecystitis. And I tell you, this is more serious than cholecystitis due to stones. Okay? तो ये उन लोगों में होता है जो elderly people, they're very sick people, and there is some biliary stasis, no stone there, and they're very, very critical. Usually diabetic patients, uremic patients, patients on immunosuppressive drugs, they're very immunocompromised, and because of the stasis of bile, which is an infected one, it causes inflammation of the gallbladder without stone. Diabetic usually, uremic, immunocompromised patients, elderly people lying in bed with some other conditions suddenly start getting pain in the right upper quadrant. You do the ultrasound scan, there are no stones. आपने फील किया तो आपको पता चला एग्जामिनेशन की तो बड़ी पेन हो रही है राइट अपर क्वाड्रेंट में there is inflammation on the ultrasound, but there are no stones. It's because of this bacteremia and septicemia due to biliary stasis. So in that case, urgent procedure needs to be done. Otherwise, it can be very serious. Acalculous cholecystitis. So usually, ये elderly people होते हैं, they're not very fit to have a general anesthesia. कई दफ़ा ऐसा करते हैं हम लोग के what we call cholecystostomy. It's not cholecystectomy. Ectomy means you remove the whole gallbladder. Okay? Cholecystostomy is you just make a hole in the gallbladder, make a stoma. Cholecystostomy. Cholecystostomy means make a stoma in the gallbladder wall. उसमें सारा वो जो इन्फेक्टेड बाइल है वो सारा कुछ उसको ड्रेन कर लेते हैं, उसके अंदर एक ट्यूब ड्रेनेज या फोलीज कैथेटर डाल देते हैं ताकि वो ड्रेन होता रहे, जिससे ये कि डिस्टेंशन परफोरेशन बैक्टीरिया इंप्रूव हो जाता है इन एल्डरली पीपल हु आर नॉट फिट फॉर सर्जरी. तो कोलिसिस्टेक्टमी की बजाय कोलिसिस्टोस्टमी भी कर सकते हैं. ओके, नाउ दिस एक्यूट acalculous cholecystitis मैंने आपको बता तो दिया है. इसमें थोड़ा सा ये है कि 5 to 10% of the cases are acute acalculous cholecystitis without stone. Critically ill patients जो कि या तो prolonged TPN पे हैं because of some problem, and this gallbladder become gangrenous, bacteremia, empyema, पस बन जाती है, perforate कर जाती है. Okay. some ये कहते हैं stasis की वजह से है, lack of antral cholecystokinin जो रिलीज है वो नहीं होती, जो ओरली को कुछ ले नहीं होते. cholecystokinin जो है गॉल ब्लैडर को कंट्रैक्ट करता है. cholecystokinin, pancreazymin, they are released when you eat something. So there's no release of cholecystokinin. Gallbladder won't contract. There is stasis of bile there. In an elderly patient who's on prolonged TPN or who are very critically ill, not been able to eat anything, तो ऐसे सिचुएशन में in acute cholecystitis patients में what you do is emergency operation is required, and usually अगर cholecystectomy possible नहीं है, they are very unfit to do cholecystostomy. Okay. Now the next is, what is cholangitis? It's an infection of the CBD, bile duct obstruct हो गई है, stasis हुआ है, सारे बैक्टीरिया ने bile duct को cholangitis किया है, and the whole infected bile जो है जो stasis की वजह से बैक्टीरिया ब्लड में चले गए, बैक्टीरिया हो गया, पूरे सिस्टम को इन्वॉल्व कर दिया. सेप्टिसीमिया कैन कॉज renal failure, and the patient can very quickly die. So the treatment of cholangitis is give adequate hydration, give IV fluids, antibiotics, okay, and make sure the renal output is good. So adequate hydration to keep the renal output going. Give them IV antibiotics, broad spectrum IV antibiotics like ceftriaxone and Flagyl and things like that. Okay. So it's a life-threatening sepsis, septic condition. You've got to be very careful about cholangitis, IV fluids, antibiotics. It's usually gram-negative septicemia. Okay, and give some other gram-negative drugs. Okay, so cholangitis and its treatment, and comes the what is a Charcot's triad? Now the Charcot's triad, Charcot नहीं है ये Charcot, शीन से होता है, she, Charcot's triad. Okay? You get pain, fever, and jaundice. Three things together: there is a pain, fever, and there is a jaundice. With raised white cell counts and raised LFTs. Okay, it's called Charcot's triad. There is a non-suppurative event. It is a suppurative event. There is a fever, jaundice, raised white cell count, hepatic encephalopathy, hypotension. That means if you get hepatic encephalopathy, it's called, and hypotension is called Raynaud's pentab. Okay, 5 things together: pain, fever, jaundice, hypotension, hepatic encephalopathy. Okay. So Charcot's triad, what is Charcot's triad? What is Raynaud's pentab? And there is also one more thing. I don't want to forget it because the last few minutes left. Called Courvoisier's law. Courvoisier's law is that in a jaundiced patient, if you get palpable gallbladder, distended palpable gallbladder, and the patient is jaundiced, it is usually due to carcinoma of the bed of the pancreas. It's called Courvoisier's law. Okay, so remember that. So Courvoisier's law is usually Viva question, and sometime also in 3-mark question in theory as well. So Charcot's triad. Yeah, man, why I'm stressing on these gallstones and stomach and ulcer, because most of the surgery, most of the problem these days are due to this gallstones, gallstone problems. जहाँ भी अपने अराउंड देखें किसी न किसी ने गॉल ब्लैडर का सर्जरी करवाई होगी लैप्रोस्कोपिक. वी सी क्वाइट अ फ्यू हमारे पास आते हैं जो सर्जरी करते हैं. आजकल थोड़ा सा स्लो हुए हैं बिकॉज ऑफ दिस कोविड प्रॉब्लम्स. हर एक का कोविड-19 PCR करवाते हैं, एंड जब तक अनडिटेक्टेड ना हो तो हम ऑपरेट नहीं कर रहे. अगर कोविड टेस्ट पॉजिटिव है, then we tell them to get it repeated after 15 days unless it's negative twice. दो दफ़ा negative होगा तो then we'll operate. Otherwise we run into a risk of getting that COVID infection. Okay, न सिर्फ अपना ही नहीं होता बल्कि आपके साथ सारा पूरा स्टाफ होता है. थिएटर स्टाफ है, स्क्रब नर्स है, assistants हैं. So you got to look after everybody. Okay, especially in laparoscopic cholecystectomy. लाप्रोस्कोपिक cholecystectomy के आप pneumoperitonium क्रिएट करते हैं, और जो ही पोर्ट्स अंदर बाहर आते हैं तो अंदर से एक पूरा गैस का एक फवारा सा कई दफ़ा लीक करता है, और वो एरोसोल में चेंज हो जाता है. सारे there are bacteria in the person infected, वो सारा थिएटर में जो है ना. इसलिए आजकल लोग जो है ना वो इंस्टेड ऑफ laparoscopic cholecystectomy जिसमें न्यूमोपेरिटोनियम का खतरा होता है कि वो एरोसोल में न चेंज करते, वो ओपन कोलेस्टेक्टमी वो जो है ना वो लोग ज़्यादा करते हैं। सर्जन भी कहते हैं यार लैप्रोस्कोपी अभी ना करवाओ, अभी ओपन करवा लो अगर बहुत ज़रूरी है तो। But if you are doing laparoscopy, you got to be very, very careful. Okay. So, gallstone pancreatitis, I've already mentioned that you do sphincterotomy, remove the gallstone, and then cholecystectomy at a later date. Okay. उसी admission में, in the same admission, पहले ERCP करो, patient is settled, remove the stone from the CBD, and then do a cholecystectomy before the patient is discharged from the hospital. Okay, in mild cases. Agar वो severe pancreatitis है, then wait till the patient general condition improves, then you can do this cholecystectomy. All right, then spectrum of gallstone disease क्या क्या हो सकते हैं, क्या पता है? Cholelithiasis, gallstones, asymptomatic cases, symptomatic cases, chronic calculus, acute calculus disease, and don't forget acalculous cholecystitis in diabetic and elderly unfit patients. Okay, so we'll carry on with this. Another just it's called porcelain gallbladder. It's a precancerous condition that needs cholecystectomy. Can you see this all calcified like a pot? It's a porcelain gallbladder. It's a cancerous, precancerous condition that needs to be removed cholecystectomy urgently. Okay, that's it then. I think it's the time. See you again sometime later, maybe next month. Thank you very much and good luck. डेट शीट मिल गई आपको, start studying. ये अच्छी तरह प्रिपेयर कर ले. Clinically जब आप आएंगे, we'll be stressing more on your clinical side, और उसी में फिर सारा कुछ आगे patients पर discuss होगा. Okay. Thank you very much and good luck. Thank you.